Welcome to the Irish Practice Nurses Association online education series for general practice nurses. My name is Teresa Lowry-Lanin. I'm a member of the Carlow branch of the IPNA, and today we will be discussing the topic of atopic eczema. Atopic eczema, or AE, also known as atopic dermatitis, is a chronic inflammatory skin disorder characterized by intense itching, dry skin, and recurrent erythematous lesions which usually develop in early childhood. The causes remain unclear but are multifactorial in nature, involving genetic, environmental, and socioeconomic factors. It can run in families and often develops alongside other atopic conditions such as asthma and allergic rhinitis. The prevalence of atopic eczema in adults is approximately 1 to 3% and higher in children at 10 to 20%. Atopic eczema affects approximately 1 in 5 children and 1 in 12 adults in Ireland. It presents at any age, but up to 85% of people affected are symptomatic before the age of 5. The condition is mild in up to 80% of patients. However, it can have a significantly negative impact on an individual's quality of life due to itch, sleep deprivation, and social embarrassment. Atopic eczema causes areas of skin to become itchy, dry, cracked, red, and sore. It most commonly occurs on the hands, especially the fingers, insides of the elbows or backs of the knees, and the face and scalp in children. The severity can vary from person to person. Although it generally presents as an episodic disease with repeated flare-ups, it can also be continuous. Severe cases of atopic eczema can cause widespread red, inflamed skin all over the body with constant itching. Triggers include irritants such as soap and detergents, environmental factors such as cold and dry weather, dampness, house dust mites, pet fur, pollen and mold. Food allergies can include cow's milk, eggs, peanuts, soya or wheat. Certain materials worn next to the skin can be a factor, and these can include wool and synthetic fibers. Other triggers include hormonal changes, skin infections, and psychological stress. The pathophysiology of atopic eczema is complex, involving barrier dysfunction, alterations in cell-mediated immune responses, IgE-mediated hypersensitivity, and environmental factors. Key components are epidermal barrier dysfunction and cutaneous inflammation due to heightened immune response. The epidermal barrier is made of structural proteins including filaggrin, whose role is to prevent water loss and penetration of environmental antigens, irritants and microbes. Loss of function mutations in filaggrin have been implicated in severe atopic eczema due to a potential increase in transepidermal water loss, pH alterations and dehydration. Not all patients with atopic eczema have an FLG mutation, and 60% of patients carrying the FLG mutation do not have an atopic disease. The greatest risk factor for atopic disease is a positive family history. Genetic changes have also been identified, which may alter the skin's barrier function, resulting in an atopic dermatitis phenotype. The imbalance of Th2 to Th1 cytokines can create alterations in the cell-mediated immune response and promote IgE-mediated hypersensitivity and development of atopic eczema. Diet and the role of the environment must also be taken into consideration. Chemicals such as airborne formaldehyde, harsh detergents, fragrance and preservatives can be involved. Harsh alkaline detergents in skin care products can alter the skin's pH, causing changes in enzyme activity and triggering inflammation. Environmental pollutants can trigger responses from both the innate and adaptive immune pathways. Diagnosis of atopic eczema is mainly based on the patient's history, clinical findings, and exclusion of other dermatological conditions. History taking involves questions about the onset, pattern, and severity of the AE, potential trigger factors such as irritants, skin infections, contact allergens, food and inhalant allergens, the response to previous and current treatment, the impact of the condition on the patient, and personal and family history of atopic diseases. The diagnosis of atopic eczema relies on the assessment of clinical features because there is no laboratory marker or definitive test available to diagnose the condition. Elevated IgE levels may be seen in up to 80% of patients with atopic eczema, but it is not a specific test for AE and is not routinely indicated. No standardized methods to diagnose AE were available until the 1980s, when Hanifin and Rachka developed diagnostic criteria. Since then, the original criteria have been modified many times, and numerous experts have developed different criteria suitable for their own environment and varying with age. Efforts to develop practical clinical criteria have proven difficult, and those available are not suitable for all geographic areas and age groups. The lack of a good biomarker for diagnosis is considered a major obstacle to the study of AD. The UK Working Party diagnostics criteria are among those most widely used. However, while the validity and reliability of these criteria have been assessed, they have not been tested extensively in non-white ethnic groups in the UK. The UK Working Party diagnostic criteria states that patients must have a history of itchy skin and include at least 3 of the following: visible flexural dermatitis involving the skin creases, such as the bends of the elbow or behind the knees, or visible dermatitis on the cheeks and or extensor areas in children less than 18 months of age. A personal history of flexural dermatitis or dermatitis on the cheeks and or extensor area of children less than 18 months. A personal history of dry skin in the last 12 months. A personal history of asthma or allergic rhinitis, or a history of atopic disease in a first-degree relative if the patient is less than 4 years of age, or the onset of signs and symptoms for less than 2 years. However, this criterion should not be used in children less than 4 years of age. This chart shows how atopic eczema is classified according to clinical severity, and it varies from clear, mild, moderate to severe. So for instance, with mild presentation, areas of dry skin, infrequent itching, with or without small areas of redness are the main presenting features. In moderate, areas of dry skin, frequent itching and redness with or without excoriation and localized skin thickening. And in severe presentation, it includes widespread areas of dry skin, incessant itching, redness with or without excoriation, extensive skin thickening, bleeding, oozing, cracking, and alteration of pigmentation. Let's now consider the diagnosis of atopic eczema. A punch skin biopsy may be necessary with atypical presentation to outrule any other skin conditions that resemble AD, such as seborrheic dermatitis, psoriasis, allergic or irritant contact dermatitis, primary ichthyosis, infections such as scabies or fungal infections, malignancies, and metabolic disorders. Atopic eczema should be differentiated from other common dermatological conditions. Allergic contact dermatitis is a differential diagnosis. The two conditions can be challenging to distinguish, and both conditions can coexist. With a history or examination suggestive of allergic contact dermatitis, patch testing that can detect delayed hypersensitivity to common allergens should be considered. Atypical presentation of atopic eczema always requires further evaluation. This chart shows the common differential diagnosis and the varying characteristics and clinical features of different skin disorders. And it shows the different features in seborrheic eczema, nummular eczema, irritant contact dermatitis, allergic contact dermatitis, psoriasis, impetigo, scabies, and more in children and adults. And this chart is useful, and you may refer back to it at various stages to see the different characteristics and clinical features involved. The complications of atopic eczema include the risk of secondary infection. Staphylococcus aureus colonizes up to 90% of AE patients, compared with 5% of healthy individuals, leading to infection and impetigonization. Signs and symptoms of secondary bacterial infection include weeping and crusting of lesions, pustules, failing to respond to therapy, rapidly worsening AE, and rarely fever and malaise. Eczema herpeticum is a severe skin infection with herpes simplex virus that occurs in up to 3% of atopic eczema patients, particularly in severely affected individuals. Children and adults with atopic eczema have an increased susceptibility to molluscum contagiosum infection. Fungal infections are common in patients with AD, in particular yeast M. furfur commonly affects the head, neck and trunk with red hypopigmented or hyperpigmented patches that may have a fine surface scale. While there are a variety of treatments that can help to ease the symptoms of atopic eczema, there is no cure. Treatment and management should be individualized according to each patient's needs. In addition to pharmacological therapy, cutaneous hydration, identification and elimination of aggravating factors, and relief of pruritus are standard. The treatment of AD can be demanding, resulting in poor adherence to therapy. So what's the role of the practice nurse and the clinician in this? Well, patient education and inclusion in decision-making processes is very important in providing effective management of the condition, ensuring the patient is understanding and compliant with their treatment and recognise any worsening symptoms. The complexities of the fluctuating condition means that individuals with atopic eczema need direction and support to understand why they need to carry out the recommended ongoing treatments, especially when their skin condition may be well or looking normal at the moment. The main treatments for eczema are emollients used every day to stop the skin becoming dry, and topical corticosteroids, creams and ointments used to reduce swelling and redness during flare-ups. Other treatments include topical calcineurin inhibitors, known as TCIs, used on sensitive skins that are not responding to simpler treatments. These medications are known as immune modulators, and they are non-steroidal topical ointments containing molecules that inhibit a substance called calcineurin, which is involved in inflammation. They're particularly effective when used on the faces of children, since they seem less likely to produce atrophy. Additional treatments used to reduce specific symptoms include appropriate medications to treat bacterial, viral or fungal infections should they occur. Antihistamines, although not used routinely, may be used for some patients with pruritus causing them disturbed sleep. Emollients are the mainstay treatment of atopic eczema and should be used even when the condition is under control. They help to restore the epidermal barrier function by forming an occlusive layer, reduce transepidermal water loss, and reduce exposure to bacterial and sensitizing antigens. Emollients improve the symptoms of itch and pain, reduce the number of flares, and reduce the amount of topical corticosteroids needed to control the atopic eczema. Aqueous cream is no longer recommended as an emollient, as it may cause skin irritation, including burning, stinging, itching, and redness. Emollients should be used in large quantities, between 250 to 500 grams per week. Unperfumed emollients should be applied 2 to 3 times daily and after bathing to prevent skin drying. Emollients are available in different formulations, including ointments, creams, and lotions. Creams are best applied on large and subacute areas. However, ointments are richer in lipids and provide more lubrication and occlusion and are useful for the treatment of dry and lichenified areas. Lotions have a higher water content and are used to cool or dry strongly inflamed or oozing lesions. Topical corticosteroids are effective in treating inflammation and pruritus associated with acute AE and are recommended as first-line topical therapy of acute flares. The most preferable topical corticosteroids are those formulated with low systemic bioavailability and a therapeutic index matched to the area of the individual's skin, particularly for infants and young children with widespread involvement. When selecting the potency of the TCS, the patient's age, disease severity, and thickness of the involved skin region and relative absorption rate should be considered. Topical corticosteroids are classified in terms of strength varying from mild to very potent. The potency of a TCS preparation depends on the formulation as well as the corticosteroid. The inclusion of urea or salicylic acid increases the penetration of a TCS through the skin. And here on the lower right, I've provided you with a diagram to show you the varying preparations of the TCSs that vary from mild, moderate, potent to very potent, with hydrocortisone 1% being the mildest and clobetasol propionate 0.05% being a very potent TCS. The least potent but effective topical corticosteroid should be applied once or twice daily. Strength is tailored to the severity of the condition and may vary according to the area of the body being treated. There is evidence to suggest that once daily application of some potent TCSs may be as effective as twice daily. High-potency TCSs should not be routinely used on thin skin such as the face, body folds, and the groin area because of the risk of cutaneous atrophy. Low-potency topical corticosteroids are preferred on the face, areas of thinner skin, and in children. However, during acute severe flare-ups, the use of short-term, higher-potency TCSs may be appropriate to control symptoms. Potent and very potent TCSs should not be used in infants less than 12 months of age, and very potent TCSs should not be used in children without specialist dermatological advice. Adverse effects include purpura, skin atrophy, folliculitis, and acne. Most adverse effects will resolve after discontinuing use, but this may take months. Topical calcineurin inhibitors, known as TCIs, are anti-inflammatory agents that inhibit calcineurin-dependent T-cell activation. TCIs are used as a second line of treatment for short-term and intermittent care. Protopic tacrolimus 0.03% and 0.1% applied as a thin layer to the affected area are authorized for use in individuals over 16 years of age, and tacrolimus 0.03% for children over 2 years. Topical calcineurin inhibitors do not cause skin atrophy and are useful in delicate areas such as the face and the groin. Adverse effects include localized site reactions such as stinging and pruritus. Topical calcineurin inhibitors should be avoided for use in individuals with congenital or acquired immunodeficiency and those treated with immunosuppressants or phototherapy. Patients using topical tacrolimus are advised to use sunscreen and minimize exposure to the sun. Wet wrap therapy involves the application of a topical corticosteroid and/or emollient under 2 layers of cotton bandages and used for short-term 7 to 14-day control of refractory flares. Wet wrap therapy using TCSs increased the risk of systemic adverse effects and should only be initiated by a doctor trained in the procedure. The majority of patients with atopic eczema respond to topical therapy. However, for patients with severe AE, immunosuppressants or phototherapy may be required. Cyclosporin, which suppresses T cells and IL-2 production, is used in first line for severe atopic eczema when systemic pharmacological therapy is required. Adverse effects include infection, renal toxicity, hepatotoxicity, hypertension, hyperlipidemia, hyperkalemia, risk of lymphomas and malignancies, hypomagnesemia, bone marrow suppression, and potential drug interactions. It's important to monitor the blood pressure, lipids, renal, and liver function on a patient taking targeted therapies. Dupilumab, a targeted therapy, has been authorized for the treatment of moderate to severe atopic eczema. Dupilumab is a monoclonal antibody administered subcutaneously that targets IL-4 and IL-13 and has shown efficacy in clinical trials up to 1 year for the treatment of moderate to severe atopic eczema. Adverse effects include conjunctivitis, herpes simplex, eosinophilia, headache, and injection site reactions. The use of systemic corticosteroids are discouraged with AE due to side effects. They can, however, be used for short-term treatment for less than 3 weeks in severe circumstances to interrupt flares and when initiating other systemic therapy. Phototherapy is a therapeutic option for those patients whose AD cannot be controlled with topical medication alone and who have extensive body spread. Phototherapy can work in tandem with TCSs to treat AD. Phototherapy requires specialist dermatological supervision and should not be used in combination with TCIs or systemic cyclosporin due to a potentially cumulative increased risk of skin cancer. The prognosis and outlook for patients with AD is generally positive, with most children outgrowing the condition by early adolescence. Patients with severe widespread disease and concomitant atopic conditions such as asthma and allergic rhinitis, however, are likely to experience poorer outcomes. Optimal management of AD requires a multifaceted approach aimed at healing and protecting the skin barrier and addressing the complex immune pathogenesis of the disease. For optimal disease management, patients and/or their caregivers should be educated about the chronic nature of the condition, the need for continued adherence to proper skincare practices, and the appropriate use and application of topical therapies. Poor treatment outcomes are often related to poor adherence, especially to topical therapies, resulting from irrational fears about adverse effects and insufficient information. A number of biological agents targeting the immune pathway involved in atopic eczema are currently under investigation, representing promising future therapies for the condition. At least 1/3 of the population of Ireland is affected by a skin condition. Between 15 to 20% of GP consultations specifically relate to skin conditions, representing between 3.5 and 4.7 million GP consultations in Ireland every year. The Irish Skin Foundation operates a telephone and email helpline service which provides direct, accessible and specialist guidelines for people affected by all types of skin conditions in Ireland. All ISF nurses are dermatologically trained clinical nurse specialists working in hospitals in Ireland. The ISF helpline is free and available Monday to Friday from 10 to 4:30, and they can be contacted on 01 486 6280. The list of the references that were used in the production of this presentation. I hope you enjoyed this presentation on atopic eczema, which is part of an online education series for general practice nurses produced by the Irish Practice Nurses Association. My name is Teresa Lowry-Lenin. I'm a member of the Carlow branch of the IPNA. Thank you for listening and watching.